Assalamu alaikum. Welcome everyone on board. Today we will just try to just have a quick review about regional anesthesia and how we it's not covering the conduct of regional anesthesia actually. The basic concepts which are required when we are planning any regional anesthesia. So whenever we think about regional anesthesia, the things which come into our mind is one of them is central neuraxial block, one is peripheral nerve block, and the third one is compartment block. Okay, so this will be uh, uh, basic three things which you should be understanding. This is one thing. In central nerve block, it's epidural, caudal, spinal, saddle, peripheral nerve blocks in which you are identifying a nerve or group of nerves and blocking them. And compartment block, you are identifying a compartment between muscles or between fascia, and you are injecting a volume, and you are not identifying any specific nerve, and you are just identifying the passage through which the nerves will be running, and you are actually blocking them. So this is the basic concept. Then very important thing is that how you can who is the exam candidate right now? I think Abdurrahman, and they are not available. Who want to answer? You know, what are different ways of performing? Yes, Mahnur, would you like to speak out?
Hmm.
Hello? Anyone wants to answer? And anyways, one is the landmark technique. Okay, that you identify some anatomical landmarks and you perform through it. Number two is ultrasound, nerve locator, and sometimes some block surgeons they are giving under vision. Okay. One thing which is actually I missed it is actually it's not you will not say it as a block, but actually local infiltration is also sort of regional anesthesia. Okay, local infiltration. Okay, so sometimes we combine the technique, like we will identify a landmark to know the place. Okay, then you identify a specific nerve or a specific compartment through ultrasound, and maybe you need nerve locator to see the needle exact positioning and how far you are from the nerve, or you can say that like just to be reconfirm or reassure about the position. Okay, so this is another important point. Then the third thing will be that like what drug you are giving. So among the drug, the basic concept is that you have to calculate the safe dose. This is the basic thing. Number one, safe dose. Then the second thing will be that what concentration you want. The third thing will be volume. Okay. The fourth thing will be adjuncts. Any adjuncts you are. And then also part of it, actually, this should also be like part of it that you are ending up applying for some endpoints through which you will identify. If you inject something and something happen, that is an endpoint. Similarly, if you in this way you also identify the wrong compartment. Like if you want to identify whether you are injecting in instead of epidural, you are in subarachnoid space or you are in intravascular space, you give a test dose. So this is how you also identify. So this may be part of, you can say, technique or part of it. And also you give some adjuncts, not only to increase the quality of the block, duration of the block, okay, and you can say avoidance of toxicity, okay, then onset of action. So these are certain reason why you add adjuncts. Like for example, I will just try to give an idea about adjuncts first. Like for example, bicarb. Bicarb will increase the like
One sec.
PK. Sorry. So it will increase the pH towards the pK and increase the uh, unionized portion so that uh, the onset will be increased. So this is one thing. One thing, for example, if you are adding epinephrine, okay, so epinephrine is to it's maybe two rule that if you are putting it for to identify whether you it in intravascular compartment, okay, so this is one thing. And the other thing it will be is that it will causing vasoconstriction, so reduce the vascularity. So what it will be doing, decrease absorption, okay, and decrease chances of toxicity. So this is the sequence of event why you are putting epinephrine. So like this is important point. Then we add opioids. So opioids increase the quality of block. The quality of block actually they don't have any effect on motor. They will increase the maybe sensory and the pain. Okay, so it will increase the quality with reference to analgesia mainly. It will not have any effect on motor. Similarly, one more thing which we add is dexmedetomidine. Dexmedetomidine is also to increase the quality of the block and duration of the block. So these are some words about the adjuncts: opioids, epinephrine, bicarb, and everything. Okay, now how to calculate the safe dose? So calculation of safe dose will be around 2 milligram per kg for bupivacaine, okay, and 2.5 milligram per kg for ropivacaine, and like according to the site, 3 to 5 and 5 to 8 for like actually 3 to 5 and 5 to 7 for lidocaine without and with epi. Okay. This is usually, there are other medications also, but they are not commonly used. I don't remember the doses, chlorprocaine, and I don't remember exactly the doses you can just have. So you should know what is the safe dose. So how you will calculate that? For example, I will focus mainly on bupivacaine, for instance. So if it is 2 milligram per kg, so usually if you are taking obese patient even, so 70 kg will be lean body weight for female and maximum 100 kg will be lean body weight for male. Okay, so this is the concept. So for example, if you are just to make it simple, I am just taking for example 70 kg, so 140 milligram. Okay, so as an adult, regardless of male female, we are taking a 70 kg, so 140 150 milligram. Okay, so round off, for example, I will say that I will just to make the calculations easy, I will make it 150 milligram, for example. Okay, so 150 milligram, if you are taking 0.25% bupivacaine, 1 ml is 2.5 milligram per kg. Okay, 1 milligram is 1 ml is sorry, 2.5 milligram per ml. I'm sorry, 2.5 milligram per ml. So how will you calculate the mls? It will with this calculation, like 150 divided by 2.5. So that many mils you can take. Okay. So around 30 mils. Sorry, not 30 mils, 60 mils. Okay. 150 divided by 2.5 is 60 mils. So you can give up to 60 ml of 0.25%. That is the basic. Of course, you don't go to the maximum. You try to be under it. This is just to have an idea that how much you can give. So this is one. And now coming back to the concentration concept, that because 0.25% or less for analgesia. Okay. And usually we for infusions we take 0.1%. Okay. So that's how you can say that how many mils you can give. If you are using it at certain places where volume will define the level, I repeat, volume will define the level as it occurs in epidurals. So you will not you can say that you okay I can give 60 mils, so let's give 60 ml. No, because it can travel to the higher levels which are not required. So concentration is one thing, safe dose is one thing, and the required volume is a third thing. So that's how you calculate. So any just to be everyone knows about it. Just but to just recall that any percentage will be multiplied by 10 that milligram per ml. So 0.1% is equal to 1 milligram per ml. 0.25% is equal to 2.5 milligram per ml. And another concentration which is available is 0.5%, which is 5 milligram per ml. Okay. And another thing is that if you want motor block, so motor block, you need 0.5%. Okay. Because the fibers, the alpha fibers for motor nerves, and they are big, and you they will not be blocked unless you give 0.5% concentration. Okay. So if you want it for surgical anesthesia, you need to give 0.5%. If you want to give it for analgesia, you can have less than 0.25% or 0.25%. So this is the basic concept. You will make the concentration, you will calculate the safe dose. Okay. You will have the volume and you will have the adjunct. Same principle is there for any block. Yes, one adjunct I forgot is dexamethasone. Dexamethasone actually increase the duration significantly. Okay, so that's how in the adjunct I forgot. So safe dose, concentration, volume, adjunct. The same principle is there for epidural. The same principle is there for compartment block. The same principle is there for any peripheral nerve block. Okay. Okay. So now the next step will be that how will you uh, like endpoints, maybe any endpoints we discuss through with but like okay, a few words about ultrasound. Okay, because I will try to touch all the concepts one by one. So actually, whenever I'm not sure whether no exam candidate has joined today. This class is for them and nobody's. Would you like to speak out any one of them? Yes, Zishan. What is the
Yes, sir.
working? What is the working principle of ultrasound?
The ultrasound working principle is basically there is a piezoelectric crystal that basically convert the sound waves into an image on the monitor, sir.
No,
The display.
the sound waves pass through piezoelectric crystals. They create vibration, and then there is a transducer which is converting it to mechanical signal, and that is displayed on the screen. You're right, but a little improvement. Okay, so sound
Okay.
waves they go through the probe, and then they touch the structures. We need a conducting material. Okay, so conducting material may be any gel or even saline. Okay, and then it reflects back according to the quality or according to the character. So bone, muscle, nerve, according to different water. So every reflection will be according to, and then that when it comes back, again the piezoelectric crystals are vibrated. So that vibration is now converted into this mechanical is into electrical signal, and they are displayed on the screen. This is the working principle of ultrasound. Okay, this is one thing. Usually for superficial structures, what sort of probe is required?
For superficial, we can use uh, s-
High
straight
frequency,
probes.
straight probes. It is
Yes.
better to use the word linear probe. You know,
सर ये प्रिंसिपल प्लीज रिपीट कर देंगे.
this there are piezoelectric crystals, sound waves, high frequency sound waves. Actually, usually the sound waves which we can hear is up to 20 to 20,000 hertz. Okay. So this is in megahertz. So this high frequency sound waves, they are uh, passing through the piezoelectric crystals. They are vibrating, then they are reflected by the structures which we are scanning, and there is a conducting material. Then it reflection, it is coming back again. Piezoelectric crystals are vibrated, and then the reflection will be according to the structure from which is it is reflected. So that is taken by the probe, and then it is converted into electrical signal and shown on the screen. This is a basic principle. I don't know the too much details, and nobody actually expect you to tell too much details. This one is enough. Okay. So coming back to this superficial high frequency linear probe. Okay. So as much the frequency, high frequency will be, that it will have more superficial view. Okay. And for deep, you need curvilinear or curved probe. Okay. So it will have low frequency and more depth. Okay, then another important concept they can ask you, that, for example, if nerve is going in this direction, nerve or vessel. So if you place the probe in this direction, what would you say this orientation, Zishan?
For short axis or
Very good. This
short
is short
axis.
axis. And if you place your probe in this direction, it will be long axis. This is one concept. Okay. Now, the other thing, the nerve is going in this direction. You place the probe in this direction. And now one direct thing is that you are passing the needle here. Okay, from here. So this is called as out of plane. Okay. And if you are bringing the needle from this direction or this direction, this is called as in plane. Okay. Am I audible? Can you hear me?
Yes, sir.
Okay. So in plane, out of plane, short axis, long axis. Usually the blocks which we give, usually majority of time we are doing it in plane and short axis. Okay. For CVP, majority of time we are short axis and out of plane, usually for CVP. For A line, again, in plane and long axis. Okay. So this is some basic stuff. Okay. So we discussed about adjuncts, we discussed about different types, we discussed about calculating the dose, concentration, and the concept. Yes, one thing I forgot to tell is the concept of differential block. Okay, so differential block is that, like, preferably you are sparing, motor sparing relatively, it is through ropivacaine. Okay, so this is one important point you should be knowing. Okay, now some of the, like, basic concept of lower limb blocks and upper limb blocks. Uh, if you just think about, because I will be telling you surgery wise, the details of the landmarks and details of blocks you can read. There is nothing out of the world. I will just try to explain to you what is the basic thing you should be knowing. Like, for example, if you are talking about hip surgery, okay, so what are the different options for analgesia? Of course, epidural and spinal will be there. Okay. So for analgesia, actually, we discussed yesterday as well. So anyone can repeat, Zishan?
Yes, sir. We can use a femoral nerve block in the form of
Block,
yes, sir. Fascial LACA block, 3-in-1 block. Then there is Pank block,
tank
and then
block.
there is yes,
So actually,
and then we can
if you give infraumbilical, so facial iliaca block, or you are blocking the femoral nerve, there is quadriceps weakness. It is not required. Okay. So this you don't want. Same principle is there in knee surgery. When you don't give femoral nerve block, you try to give which block for knee?
adductor canal,
Adductor canal. And your target is to block which nerve? Saphenous nerve.
definitely
And another nerve, nerve to vastus medialis.
obturated.
No, no. For knee surgery.
Yes, in nerve to vastus medial.
Okay. There is another block. I don't remember the too much details. Plus, please do have few words about this IPAC. Okay. I think infiltration. I forgot. I just need to recall, but to read about this IPAC block. Okay. And for knee, if you want to cover the whole of the knee, actually you need some branches from sciatic nerve as well. And oh, anyway, okay. So what about foot? If any surgery you want to tell about foot surgery, so you need to block both femoral and
And branches of sciatics.
sciatic. So if the surgery is foot, okay, do you need to block something like you can do ankle block is enough, or you want something else as well? Yes, please. What thing will define that you need some other block as well or no? You understand my question, Zishan?
No, sir. Are you asking about the level?
Tourniquet.
Tourniquet, yes, a tourniquet pain.
So for tourniquet, which nerve you need to block? Femoral, obturator, even for the backside sciatic, and even lateral femoral cutaneous nerve. Okay. Otherwise, a tourniquet pain will be a problem. For that, you need to block higher level. Okay. So that's why the traditional texts often state that small diameter zones such as C. Yes, about the sensitivity to local anesthetics. Traditional texts often state that small diameter exosomes are more susceptible than large diameter. However, when careful measurements are made of single impulse annihilation in individual nerve fibers, exactly the opposite differential susceptibility. I'm really sorry. I have no idea about it. I just have this concept that small fibers will be blocked first. That's why autonomic fibers, which are the smallest in low diameter, they are blocked first, and the motor will be at the last. And similarly, when the reverse occur, the same. The last to go will come first, and the last thing to come back will be the autonomic fibers. I have no idea about it. Okay, so tourniquet, any confusion about it? Okay.
No, sir.
So for tourniquet, you need to block these. There will be less involvement of sciatic nerve, but at least femoral, obturator, and lateral femoral cutaneous nerve needs to be blocked. Okay. So for hip surgery, for knee surgery, for foot surgery. So you should, because usually there is less involvement unless there is a coagulopathic patient in which you are not able to give spinal or epidural. That's why the utility as a surgical block is relatively less. Okay. And this is one reason. And one other reason is that you need to give a lot of volume if you want to block both sciatic and femoral component. Okay. So actually, sometimes it becomes very difficult to give if you have a bilateral surgery, or even if you have unilateral surgery, you need to give a lot of volume. So that's why the role of using the nerve blocks for surgical anesthesia is relatively less. Okay. So this is an important point which you should be knowing. Okay. So some few basic word about upper limb block. So actually, interscalene block usually it's good for shoulder surgery. Okay. It is blocking the trunk. So you can say root and trunks. So C5, C6, C7, they are blocking the roots, not trunk. So uh, interscalene, they are good for shoulder surgery. Okay. In the interscalene groove. And what are the important points about it? Important
Sir,
point.
it can,
Yes.
sir, it can associated phrenic nerve can also be anesthetized
Yes. Phrenic nerve,
with this blocks.
vertebral artery injection, if occurs, fits. Okay. And if you are going too deep, you can have this total spinal and higher, things like that. Okay. And phrenic nerve involvement is very important. So whenever we are giving interscalene block, you have to be very careful. One more nerves group which needed for shoulder surgery will be superficial cervical plexus. Okay, because some of the nerves in the supraclavicular fossa and some nerves we need to have superficial cervical plexus block as well. Okay. Okay. So if you want to have a surgery on humerus or above elbow, or this uh, supraclavicular is like the spinal of upper limb.
On.
Okay. So what is the advantage? Why it's good as compared to infraclavicular? What things will be good for supraclavicular as compared to infraclavicular?
Sir, in infraclavicular, there is more chance of pneumothorax intraclavicular.
Because because infraclavicular is a deep block. Okay.
Yes.
So deep block sometimes difficult, and there are chances of pneumothorax. Actually, there is a coracoid, because I don't like infraclavicular, I hardly use it. Um, but there is actually a special technique in which you are going a little lateral, and it is avoiding the involvement of lungs. I think, if I'm not wrong, it is coracoid technique or something like that. I don't remember exactly, but actually it's a deep block. So if supraclavicular, it's superficial and it's very easy to block. Okay. So the landmarks are very easy. You just put your probe above the clavicle, find the subclavian artery, just supralateral to that, you will find dense place. It's easy, relatively easy. Okay. Someone now ask about axillary. So what will be the advantage of axillary? What will be the advantage of
Sir,
axillary block?
sir, advantage is that we can block individual nerves individual nerves are visible, so we can block
What is the
the
advantage?
individual.
What is the advantage of it?
Then in other blocks, maybe ulnar nerve or may nerve, single nerve can be spared, but in axillary you
Mm,
can.
okay.
I think it's more shallow and you can compress it if it's
I'm
bleeding.
sorry. I'm sorry. Please
It-
again, a little loud, please.
it's more shallow and you can compress it if it's bleeding.
This is yes, this is one valid point because it's a shallow, it's not a deep block, and you can compress the vessel. But there is another advantage. You should, in
And,
exam they are
and it,
expecting a very simple answer: pneumothorax. There is no chance of
Pneumothorax.
uh,
pneumo. Okay, there is no chance of pneumothorax. This is one thing. Number two, supraclavicular need more time for its effect.
yes,
Okay,
faster.
because they are thick nerves, so it will take more time to penetrate to block the nerve. So axillary will be quicker. If you identify, you inject it, the nerves will be blocked much quicker than supraclavicular. Okay. And actually, I have just made a technique. Of course, this is not a very bookish technique, but if you inject supraclavicular and now few mils, you keep it and you inject in axillary, I have seen that the results are even much quicker and very good. So I just keep a little bit of lidocaine to be injected at the axillary place at some time. Okay. So of course, this is not a bookish thing, but I have practiced this a number of times. If I want a quick effect, I inject some remaining volume in axillary, but don't tell in the exam. This is just a practical point. Okay. So in axillary, you are identifying the individual nerves, and Zishan, the problem will be that you cannot spare. Like there is no guarantee that you will only block the median nerve or you will only block they will because you are spreading it and it will go all around. Yes, you need to put it in separate places. Rather, here another problem will be that you have to, if you want to block the musculocutaneous nerve as well, so you have to block it all the way separately in the coracobrachialis muscle. Okay. This is another important point. And a number of times for the tourniquet, you need to block intercostobrachial nerve as a wheel in the upper one third of the arm, and also for the medial cutaneous nerve of arm. Okay. So these nerves are separately blocked here, just by blocking a wheel just in the upper one third of the arm. So this is some words about this thing. And for shoulder surgery, interscalene, for humerus and for arm fractures, usually it's better to give supraclavicular. Infraclavicular has almost the same indication as supraclavicular, but as I know that, as I told you, that there are some complications which are associated with it, so it's not a very frequently used block. Axillary nerve, individual nerves are blocked and quicker, as I've explained to you. So, if you want to block to do it for the um, hand surgery, again you have to, for the tourniquet, you need to even block up to the musculocutaneous nerve even. Okay. So that's why you need to cover always think about the tourniquet. Okay. So another important point is that when you have any trauma and you have any suspected nerve injury, of course, okay, a question is that you give a block. Okay. And after the surgery, the surgeon is saying that the patient is not able to move the hand. How can you identify whether it is not by you and it is from surgical manipulation? Yes, Zishan.
Sir, we can use nerve stimulator, sir.
Nerve stimulator, how it will tell?
Sir, if the motor, there is a motor blockade from our due to drugs, then response would not be elicited with the
Actually,
neurostimulator.
answer is a little different. It's MRI. Like the question is that because if you have given supraclavicular block and you have damaged, so there will be edema around that place. Okay. And if the surgeon has a humerus fracture and a radial nerve was involved and there is this drop, so it will be evident. Okay. Nerve stimulator, how will you identify whether this is brachial plexus injury by you or by the radial nerve injury by the surgeon? How can you identify this to nerve stimulator?
Yes, sir, we cannot differentiate it. It will only tell us that there is a
So that the
blockage.
question is that, okay, that you want
Difference.
to
Okay.
identify whether the damage is done by you, not by the surgeon. Okay.
Yes.
Someone has asked a regional recommended book for regional block procedures. Remember one thing, I like my answer to all these questions is articles. Okay. So like don't expect that I will tell you a book, because this in 2025 is not era to read the books. Okay. Hadzik, can you read Hadzik? It's I think 3,000 pages book. Would you like to read Hadzik for it? Oxford is a good book. There is Oxford book of regional anesthesia as well. You can have a look. But actually, why the thing is that I will show you the article. So why you people don't believe in articles? Why you people are running away from the articles? Everything is written in articles. Res- these are not review research articles. These are review articles. Okay, so review articles, books are written from the review articles. But unfortunately, Vakas, because you people have that thing so much imprint in, like what I say, that there is no way you can come out of books. So please, I want you guys to come out of books and have a critical thinking of the subjects rather than book, because book has limited scope. Book will be written in a specific pattern, and majority of time there will be not updated. The book will be written many years before, okay, and you will not be able to have the latest. So my call is always use articles. Okay. Tourniquet injury, MRI. I think tourniquet injury will also be evident through MRI, because MRI will identify individual nerves, huh, at what level it is blocked, what level there is edema or something. And of course, then I think nerve conduction maybe future. Anyways, so this is some basic concept about upper limb and lower limb block. Some words about compartment block, then we will have some words about epidural and spinal. Compartment blocks actually, like, okay, can you tell me what are if various compartment blocks?
Sir, erector spiny block.
Okay, what else?
Mm. The fascia iliaca block is also a compartment block.
Okay,
A paravertebral block is also.
you are not telling the common blocks, you are telling difficult blocks. The commonest,
Sir, tab block, sir, tab block.
yes. Okay, so tab block. What else? Rectus sheath block, QL
Correct.
block, erector, this PAX blocks. Okay, PAX blocks. And so the basic concept is that you have to identify a specific compartment and you have to inject a big, relatively large volume, whether it is tab block, whether it is QL block, whether it is subcostal tab, whether so actually some utilities. So tab block actually is covering the lower abdominal anterior abdominal wall nerves, and it is does not give you somatic, so it does not give you visceral analgesia, it only gives you somatic. So that's a limitation of tab block. If you want a higher nerve roots, you need to give subcostal, which is a little higher. Rectus sheath block is good for midline midline incision. Okay. Erector spiny block, the concept is that there is a, like, in the posterior spine, there is a potential space where if you inject a high volume, it will block the nerves coming out. Actually, practically, I have used erector spiny block very successfully, and I have used it even for laparotomies. The only problem is that you need to make the position in a lateral position. You have to give bilateral, and ideally, you should place a catheter. Okay, because if you place a catheter, because you are using the TUI needle, so actually it is a big needle. So with that, you can use actually spinal needle as well, but ideally, under ultrasound, you can identify the bony mark, landmark, and then you inject it. And the concept is it's better to place the catheter. Okay, but for need, of course, catheter placement, you need practice. So that is something. PAX block. So. mm Actually, I will discuss another session on separate surgeries. I think I will leave PAX block and some of the blocks for that discussion, inshallah. I'm leaving PAX block. I will discuss with breast surgery. Okay. Uh, just actually, I missed a very important point with reference to performance of blocks. That is role of antiplatelets and anticoagulants. So how you manage if the patient is on anticoagulants on and antiplatelets? Yes, Zishan,
There is the
Rahma.
patient is on anticoagulants, antiplatelets, then it should be bridged according to the surgery and according to the block, sir.
Okay. Like, for example, if the patient is on heparin, what you should do? It will depend on the dose. If it will depend on the risk, yeah, like you just have to do risk versus benefit. If you can
Okay.
stop heparin 4 to 6 hours before, you can give. Okay. But again, I will tell you something that if you want to resume, that was the discussion even in Dr. Fazal class, it was being discussed that in the exam, if you want to be safe, so you can just practically whatever you want to do, it's your call. But in exam, if you just identify that if you are giving epidural and later on, you patient needs to receive heparin or Claxane or in a slightly higher dose, it is always a question mark. Okay. So if you don't want to give it for this reason, you can say that I will do risk versus benefit. And if it is strongly indicated, only I will put it. If there are some alternative to epidural, I will try to avoid. If you answer like this, they will never fail you. Okay. So you can always say like this with reference to anticoagulants or antiplatelets. Okay. Because aspirin, they claim that aspirin no need to stop, but practically I will tell you that it's always a tricky thing. The guidelines say sometimes something else, but practical, I always fear. Guidelines say that if the patient is taking aspirin, you can give, but practically I don't know how safe it is to give if the patient is already taking aspirin. Okay, so this should be. And actually, if they ask you about any new medications, please have an idea about the half lives of that medications. That how much is the half life? Okay, one question. Usually, how much half lives you need to clear? I know that this is not a relevant question at the moment, but can you explain to me?
Sir, I read somewhere that it almost take 4 to 5 half-life for a drug to completely eliminate from the body.
Do you know the reason how it happens? So 100 to 50, 50 to 25, 25 to 12.5, 12.5 to 6.25. So one half life, two half life, three half life, four half life. Now 3.125. So if it reaches up to this one, the clinical effect will go. So it needs around 5 half-lives. 1, 2, 3, 4, 5. Five half-lives to finish the clinical effects. Okay. This concept I didn't understand for many years. So I just it come across. So that's why you should be knowing that what is the concept. Okay. And if they are asking you in the exam, if you say like this, as I explained to you, that anticoagulants and antiplatelets, you have to do risk versus benefit. If you are giving superficial blocks, uh, you can, if you are giving it under ultrasound block, it's relatively safer. If you are using spinal, it's relatively safer. If you are giving epidural or anything in which you are using a big needle and you are placing a catheter, so you have to be careful. You should better do risk versus benefit. This is the basic concept for all blocks. And then you should be knowing that if you have placed a catheter and if you have given heparin, and after how many hours you need to stop before it. So it's different for for heparin, 1 to 2 hours, and similarly for other, like these are things which sometimes slipped out of mind, but you should be knowing after how much time for individual agents you need to stop before removing. Okay. Okay. Actually, buyer's block, somebody has written about buyer's block. I know that some people still ask about this IVRA. As a principle, this this block is obsolete. It's a terrible block. It's a dangerous block. If you are using it, of course, all of us back in Pakistan, we have used it with a terrible tourniquet. Without pneumatic tourniquet, there is no way you should give it, but still people use it. But I don't know, with the evidence of, with the like availability of ultrasound, there is no compelling indication to do IVRA. But for our exams, you should know about it. How you will perform it, how will you calculate, how will you calculate the dose. I'm sorry, I totally boycott this IVRA. But the basic concept is that you will put two tourniquets, okay, and you will take separate IV lines, one on the side where you are giving the block. You will initially uh, you will have the proximal tourniquet inflated, and the distal tourniquet will remain open. Okay. And after that, after some time, when there is slightly pain on the upper tourniquet, you will inflate the distal tourniquet first, and then you will open the proximal tourniquet. This is the thing with reference to the pain with the IV, this tourniquet. And the rest of the thing, which prilocaine is being used. Okay. So, or lidocaine 1%. And when you finish the surgery, you gradually open it. Okay. So this is what I know. Prilocaine is associated with which complication? Methemoglobinemia. Okay. What you do with methemoglobinemia? Methylene blue.
Methylene blues.
Okay. So it's 85% saturation will be coming. Okay. So because we have limited time, I just want to have speak some words about how will you use epidural for labor analgesia, as well as generally what the basic principle related to the dose is the same. Okay. So now how troubleshooting, a little bit of troubleshooting, and you identify the space, you like one more thing I just strike my mind, that consent for labor analgesia, you should be knowing the incidence. Okay. There is an epidural card which I think I have placed somewhere here. I will share with you that what is the incidence of various uh, complications. Okay. Whether it is PTPH or epidural hematoma, or I think this one. Yes. 1 in 50 hypotension, 1 in 10 impartial or incomplete. Okay. 1 in 100 headache, 1 in 1,000 nerve damage, 1 in 13,000 permanent epidural abscess, 1 in 50,000. Okay. Meningitis, 1 in 100,000, and around 1 in 200,000, it's epidural hematoma. And so you should be knowing about the incidence of these things. It just struck my mind. So usually what questions they are asking you with reference to labor analgesia, how much dose you will be giving. If you have placed, usually to start, initiate, how much dose you will give. Yes. If you have, it depends on the stage of delivery. Okay. But usually 10 to 20 ml, how much will you give?
Sir, we use 0.0625% to 0.1 to 5% with fentanyl,
Okay.
around
2
50 to
mics per ml.
100 microgram per ml. And
No, 2 microgram per ml. 2 microgram per ml. And actually 0.0625 is a little difficult to calculate. Actually, it's 0.1%. Okay.
okay, sir.
So initially, when you initiate, you give 5 to 10 ml bolus. Okay. And then
Okay, yes, sir.
5 to 10 ml per hour. And you can go
Yes,
up
sir.
to even 20 ml per hour. Okay.
Yes, sir. For first stage of labor, and for
Yes.
second stage of labor, there is there is increased dose, increased volume, that is around 15 to 20 ml.
Yes.
Incremental.
And you give a sitting dose. Okay.
Yeah.
You
Yes,
can
sir. Yes, sir. Sitting dose.
you can give a sitting dose. And another thing is that, for example, if you have called that the epidural is the pain before it was working, now it's not working, you can give a bolus. Still, there is a problem. You can withdraw, you can remove the dressing, withdraw maybe one, like half centimeter or less than even half centimeter, few millimeters, and then you can give a dose. So sometime, because it's in the reason of that it is patchy or a unilateral thing
Yeah,
like that.
unilateral. Yes.
Okay. So this question they
Yes.
can ask you, and another question with reference to that, you have given a epidural, and now the patient is going for surgery. There is fetal distress or something. If they say fetal distress, should you give a dose or you should go for GA?
Sir,
Sir,
if
when
fetal distress in second stage of labor, then we will go for GA.
Okay, and first stage of, well, of course, you don't need to tell first or second stage. The word fetal distress come, you don't have to take a chance. You can say there is a new concept of rapid sequence spinal. What is this?
Sir, it is a process in which you perform a rapid spinal just by laterally in lateral
Lateral,
position, give a quick dose.
lateral, and no preloading. You do a co-loading together and you give in a lateral position. Okay. So this is just a concept you can just tell, but of course, GA is a better answer. If there is a time, so how much dose you will give?
Dose for spinal, sir?
No, dose for epidural top up for cesarean.
Sir, we have to
Approximately,
block up to T4. So we will use higher doses or higher concentrations, about 20 to 25 or 30 ml
You
or
are missing
0.5%.
something, that you have to identify how much dose is being given recently. Okay.
Yes, sir.
Because,
Yes,
for
yes, sir.
example, if you
Yes.
have given a lot of dose recently in other dose, so you have to calculate the dose accordingly. You will not give blindly. and you will not say that you have to give 0.5% now. But that's why, again, that if you tell that you have to calculate in last half an hour to 1 hour how much dose has been given, if there is any top up given, okay, so you will calculate accordingly. But usually, as you mentioned, that you need to have a level up to T4 autonomic, okay, T4 autonomic. So like you should be considering this point. So this is another important point. And at any point of time, if they need to get the effect quickly, you will not take a chance, and you say that I will go for GA. Okay. If you are giving GA on top of spinal or epidural, always say that there will be more chances of hypotension. Okay.
Yes.
So you have to anticipate hypotension. You can use lower MAC, and you can give fluid replacement. So never forget about
Sir,
this thing.
in emergency situation, can we use a combined spinal epidural? Epidural is firstly placed, and then we can use epidural
You know,
with
remember one
with
thing.
epidural.
Don't try to give a fancy answer in a simple situation. Combined spinal
Okay.
epidural in an emergency situation.
Uh,
I would,
because there will be less time to set to take motor block
no.
with the
The thing
spinal.
is that will be if in emergency. What do you mean by emergency?
Mhm.
Okay. I hope you
Okay, sir.
understand. Practically,
Okay.
whatever you are doing, practical conduct of anesthesia is totally different. CSC takes more time. It's a
Yes,
complicated
sir.
kit. You have to
Yes.
identify the space. You will put the needle. You will give the spinal, and then you have to attach quickly. Actually, if you ask me, it's a crap kit. It's just a pharmaceutical companies. There is no much advantage. I found it a crap. I always use separate. Whenever I want to
Yes.
give it, I use separately. But of course, there is the only safety that catheter may tear. If you have given epidural, you have placed the epidural catheter first, and now you are trying to give spinal. Now the only thing is that it can shear the catheter. So this is the only one thing you have to be careful. Okay, that's why you should not place epidural catheter more than 3 to 5 centimeter. Okay, you should not put spinal epidural catheter more than 3 to 5 centimeter in situ, because otherwise there are chances of unilateral, there are chances of these things, these problems. Okay.
Okay.
Okay, one more question came into my mind. How to assess the level of spinal or epidural? Three things you need to check: autonomic,
Sensory and motor.
sensory, and motor. For motor, what
Two
what
blocks.
Autonomic.
for motor, what you do? Bromwich scale. For sensory, you just have
Holes.
a touch with gauze or anything. For autonomic, how you check?
Cold sensations.
Cold
Response to
sensation
cold.
and fall in BP. Not
Drop
100%
BP.
reliable, but fall in BP is one thing, and cold sensation. Okay. Fall in BP is just a subjective, and objectively you need to check the levels. And ideally, you should always check the levels. Unfortunately, we don't check it. If you don't have cold, you can just use any like even you can use the laryngoscope blade. It will be cold. So anything which is cold, relatively cold, you can touch. Even before we used to in our medical examination, we used to have this hammer. The back of the hammer has metal, so we used to touch that thing. So for anything, you can do like this. Okay. So, like, uh, epidural, spinal, caudal, we had discussed in pediatrics a little bit, and some of the points are still missing. Uh, For the regional anesthesia, upper limb blocks, lower limb blocks, neuroaxial anesthesia. There are so many books, you just you can have all of these things uh, like as a quick review. Somebody was asking books. I never asked you to follow a specific book. Topics are more important than reading any book. But these like the sources which I have collected, all of you, you can search. You will find so many things. Of course, in the ultrasound, you need to have this Doppler color to just see the this one vascular things. I'm just trying to have a look on some of the things. What is difference between total spinal and high spinal?
So total spinal is when there is an involvement of uh, cranial nerve which causes central apnea, then it is total spinal. And high
Okay.
spinal is then when you have targeted a certain level and you achieve higher level than that what you have in mind, then it is high spinal.
Usually high spinal, you will say if you have involved the upper thoracic segments, which can cause bradycardia and sympathetic
Very
block. Okay. So the
yes.
cardio acceleratory fibers will be blocked. But how will you, and the apnea caused by total spinal will not be reversed immediately. Okay. And the apnea may be caused because how apnea can be caused in high spinal?
It
Hyperperfusion,
can due to the
hyperperfusion
hypoperfusion
of the
of
brainstem.
brain stem cell.
Brainstem. Okay. So transiently, but as soon as you improve the blood pressure, you gave fluid, you gave vasopressors, and if the blood pressure is improved, the apnea will come back. The patient will start breathing. But if it is high spinal, the diaphragmatic nerves are sorry, the phrenic nerve is involved, the cervical segment is involved. Now, till the time bupivacaine will not be metabolized and removed from the circulation, then till the time the patient will not be able to breathe. Okay, so this is one thing. Another thing, few words about this PDPH. So PDPH, how why it occurs PDPH actually?
So it happens because of stretch of the meninges due to the leak that is happening from the epidural CSF, sir. It stretches
Okay,
the meninges.
okay. So what is the character of epidural? Sorry, this PDPH.
So it's positional, sir. It get aggravated when patient is sitting or standing.
Okay, no character me like where it occurs.
Sir, mostly it is frontal or occipital.
Yes. Okay.
Sir, CSF
So
pressure actually tension on the brain and neural structure.
yes. So what is the differential diagnosis? You should be knowing the differential diagnosis.
It can be due to postpartum eclampsia or it can be migraine.
Okay. What else? Some cerebral vasculature problem like cortical vein thrombosis.
When cerebral vein thrombosis, migraine, or trigeminal neuralgia, atypical headache, cluster headache,
Drug wi-
things like
drug withdrawal.
that.
Ye- Yeah, like you just have to be understanding what is the pathophysiology, what are the differential diagnoses, and they can ask you about this thing. You see, that's 15 minutes
Sir,
of sitting, standing improves this differential diagnosis. Yes, this one.
sir,
Tension.
one question, please. Sir, is
Yes.
PDPH pathophysiology? Uh, is there a meninges involved, or is the low ICP because of leak
Stretch.
and
Whenever there is,
compens
it is meninges will be stretch. You see, CSF will be
compensatory
leak.
cerebral vasodilation?
That is also one reason, but resulting downward traction of meninges. Okay.
Okay,
And
sir.
then
Okay.
the second thing also came. Additionally, there is compensatory cerebrovascular venodilation. Okay. So this is
Okay.
stretching occurs and both the things occur. I think this is a very good source. Here, this is, you see, differential diagnosis, tension, headache, preeclampsia, sinusitis, migraine, meningitis, okay, intracranial hemorrhage, intracranial mass lesion, because there may be some diagnosis which can occur out of nowhere, okay. So, like in this, the traditional conservative methods, but remember one thing, if you are saying bedridden, sorry, bed rest, you should not forget that DVT can occur. Okay. So that's why they don't consider DVT bed rest. They can give caffeine or this uh, uh, like sumatriptan blood patch, and I think it's not written here. I have not used it, by the way, but neostigmine is being used for the treatment of PTPH. Please read about it, how you give it. I don't remember how much is the dose, but they give IV neostigmine. Okay, read about it, how it is. This nerve blocks, they have also written greater occipital nerve block and saphenopalatine ganglion block. Okay, so okay. They can also ask you about this, how to give blood patch. So how much volume you give, when you will stop. This is a question they ask. Okay. So I think 20 ml, and if
10,
you
10,
start, sorry,
10 to 20 ml.
yes, and if you started having pain, you will stop. Okay.
Okay.
So this is one thing, and I think first up to 80%, and I think after second blood patch up to 95%, something like that, if I remember somewhere I read before. And another thing is that always remember this thing, that when you are doing the epidural blood patch, there is chances of another blood PDPH. Sorry, another dural puncture. Okay, so no, never forget to tell this, that if you had a difficult epidural, you have to consider that you can have another puncture. Instead of blood patch, you you did another disaster. Okay, these are just simple common things. So I just try to give you an overview. Of course, I did not give you individual, but remember one thing: any block, landmark, okay, technique, end point. What is the end point? Endpoint means, if you are using nerve stimulator, what contractions you will be feeling. If you have given spinal or epidural, what will be the endpoint? So any endpoints, this is one thing. Then another, what is the safety? No, nothing is 100% safe. Combination of landmark, ultrasound, and nerve stimulator will give you relatively better result, but there is nothing which can prevent the intravascular, intraneural. Fourth thing I forgot to mention up till now is the pressure. Okay, there are specific equipment by which you can measure the pressure through which you are giving the injection. When you are giving the injection, it should not be, just reconfirm. I think it is around, how much pressure do you remember? I think 15 millimeter of mercury. I don't remember the number. Just reconfirm that how much should be the injection pressure. Okay, just reconfirm the pressure. I don't remember exactly. You should know about it. There is special equipment by which you can measure the pressure. Practically, what you can do, don't use 50 cc syringe, even don't use 20 cc syringe. So I try to, even if you are giving peripheral nerve block, even if you have to give 20 or 30 ml, always try to use 10 ml syringe. Okay, because relatively more pressures will be generated if you are using 20 cc syringe than 10 cc syringe. Okay, because the concept is force per unit area. If you have bigger syringe, you need more pressure to give. So unintentionally, you can generate more pressure if you are using a bigger syringe. So if they are asking you this question, how you can prevent nerve injury? So landmark, ultrasound, nerve stimulator, and use of smaller syringe, and if possible, if you have available, the syringe pressures. So these are 5, 6 things they can ask you, how to prevent regional anesthesia nerve injury. Okay. One topic is associated, I will discuss in a complication setup. So that is last. Okay. So, but generally I have tried to cover the main points. Okay. So if anything I have missed, pardon me for that. And the articles here, someone was asking about the blogs. So all blogs are here. You can have a look on these. Nysura is a wonderful source. Okay. So even now in the exam, in the talks, even they can ask you, or even they can give you a pictures. They can give you pictures of various blocks. So you should have your eyes. You should tune your eyes for these things. Okay. So I will stop here, and inshallah, tomorrow Dr. Fazal class is tomorrow.
No, sir, Sunday को है 9 a.m.
Sunday. Okay, if it is on Sunday, then we will have a session tomorrow, inshallah. Okay.
No, sir, it is on Saturday.
It's tomorrow.
Anyways, you can
Saturday को है.
confirm. Okay, if it is on Saturday, then I will have a session on Sunday, inshallah. Okay. So thank you very much. And actually, I have discussed this topic in detail before. Individual nerves I have discussed before as well. So inshallah, you can have a look on the recording. I will share the recording of the previous sessions as well. So thank you very much, all of you, to join. Bye bye.